The common assumption about NHS wait times is that the solution is straightforward. See more patients, hire more staff, open more clinics, and with enough funding and political will, things should get better. And look, that's not an unreasonable thing to think. It's intuitive. It's what most people believe. But I've been a clinical lead for 2 years now, and here's what I think that framing misses. My name's Joe Magnali. I'm a consultant ENT and hearing implant surgeon at University College London Hospital. And as well as being a hearing implant surgeon, I'm also clinical lead for adult ENT in our department. And that means part of my job is managing the waiting list for one of the busiest ENT departments in the country. And I want to use this video to explain honestly why I think NHS wait times are so difficult to fix. Not to make excuses, but because I think the problem is genuinely less understood than it should be. Timestamps are below, and I'll make sure captions and translations are available. So let's start with the basics. NHS waiting lists exist because demand is greater than capacity. When the number of patients needing to be seen exceeds the service's ability to see them, the queue grows, and when capacity outstrips demand, it shrinks, which means there are only two main levers available to anyone trying to reduce a waiting list. You either increase capacity, the ability to see and treat more patients, or you reduce the demand, the number of patients needing to be seen. Everything else is a variation on one of those two things. Now, both sound straightforward, neither of them actually is. Let's start with demand, because there's something about NHS demand that most people don't fully appreciate. See, when a GP refers a patient into my ENT department, that typically doesn't generate just one appointment that we can see and sort and solve. It generates a chain, an initial assessment, some investigations, that includes hearing tests, CT scans, MRI scans, sometimes blood tests, a follow-up to review the results, and then a discussion about treatment options. That sometimes includes surgery. Do you particularly want to rush someone into surgery? They might need more than one appointment. We might need a preoperative assessment, the operation itself, the post-operative follow-up. Sometimes that means more than one. And so a single patient can generate, at the very least, 5, 6, sometimes 7 appointments, maybe even lifelong care before we can even think about calling them discharged from the service. And what that means is, if you try and fix a waiting list by just rapidly opening lots more new slots and increasing the number of new patient appointments, new patients coming into the system, which perhaps is the most common instinct, you don't actually solve the problem. You risk just moving it downstream. The follow-up backlog grows, diagnostic services become overwhelmed, the queue feeds itself. And this is why measuring a service by the time to wait for that first appointment, in my view, is a significant misdirection and really quite problematic in terms of public relations. It measures the time to the start of the journey. It tells you nothing about whether the rest of the journey can actually be delivered safely and well. Now let's look at the capacity side. Now, when people say just open more clinics, I think maybe there's this thought that somewhere in the NHS, there's a surplus of clinician time, rooms waiting to be used. That's not really the reality of anywhere I've worked. Capacity, of course, means a trained clinician with the right knowledge and skills, supported by appropriate support staff, working in a suitable room, which is equipped with the right specialist equipment. So in ENT, for example, ear surgery needs an operating microscope with suction, specialist instruments, facilities to perform hearing tests. You can't just run this clinic in a repurposed meeting room. And at the Royal National ENT Hospital, where I work as clinical lead, our room utilisation is very carefully tracked. It's the key to unlocking our capacity. And at every room, every session of the working day is allocated. We make sure that we are at capacity. So if we're at capacity, where does that additional capacity come from? This is where the genuine dilemmas begin. One option is to extend into the evenings and weekends. That involves real questions about pay structures, timetabling, and the impact on staff well-being, family life, burnout avoidance. And these are structural tensions that any honest conversation about NHS capacity has to reckon with. Another option is investing in brand new facilities. That needs capital investment, planning permission, construction. That typically needs years of lead time. Another is training other healthcare professionals, maybe people who are not doctors, to safely take on some of what consultants currently do. That can work, but it requires robust training, supervision and governance to make sure patient safety isn't compromised. And it also requires buy-in and trust from the general public and can be really problematic if it's not managed safely. Now, the demand side, and if anything, this is even more complex. One option is to limit what a service provides, to stop treating certain conditions, or to raise the threshold for specialist referral. This does reduce the demand. It also raises serious questions about patient safety, equity of access, and clinical governance. And these are genuinely difficult conversations that require patient and public involvement and democratic accountability. Another approach which we have tried to employ is smarter triage, making sure that not every patient needs to be seen by a consultant surgeon, but training up doctors with non-surgical training backgrounds, utilising the skills of specialist nurses, allied health professionals such as audiologists, to assess certain categories of patient with clear escalation pathways. Now, having worked on some of these models, I support this in principle if it's done well. The challenge is establishing what's safe to delegate and making sure training and governance are adequate. A third approach is reducing the volume of long-term follow-up. This is difficult. It relies on culture change and making sure that the trust between patients and doctors isn't broken. Now, at UCLH, for example, we've been trialling patient-initiated follow-up, PIFU as we call it, and it's a little bit of a halfway house. Rather than automatically booking every patient for a planned review in the future, patients are instead given a direct route to come back if their condition changes or a decision needs to be made. Now, it shifts some responsibility onto patients whilst maintaining a safety net. But again, it requires careful management, and it requires patients to understand and accept a different kind of relationship with the service. And I want to share with you something that happened recently because I think it illustrates the problem very well. I recently referred a patient to another service in another hospital and was told that the waiting time for their first appointment was going to be nearly 18 months. 18 months. And I'll be honest, I even found myself thinking, at that point, is there any point anymore? Is there any point to that service if the patient has to wait so long just to be seen? And what is it going to mean for their overall care? But I also know why exactly those numbers happen, because I manage a service myself. When wait time targets become a political problem, the instinct from those outside is to reach for the most visible solution, create new appointment slots, throw money at locum staff, using evening and weekend sessions, direct money at the headline number, and on paper, the wait time comes down. Except what happens downstream? Those additional new patients, as I've said, need scans, investigations, and if the scanning services, if your infrastructure hasn't grown to match the growth in population, if your follow-up numbers haven't also grown, and therefore if your staffing numbers haven't grown, then you are just creating bottlenecks further down the pathway. And remember, some of these patients are going to need surgery. They deserve a careful, unhurried conversation about the operation, about the risks and real-life implications. I can't afford to be rushing those patients into decisions. And if we have created downstream parts of the pathway that are in bottleneck, the exact stages that matter most, that's when care quality suffers, when complaints increase, incident reports go up, triggering internal investigations to be opened. And who manages the internal investigations? Of course, it's the clinicians that are meant to be spending their time seeing those patients. It takes their focus away from patient care, from long-term strategy, and it becomes a bit of a cycle. So when the headline improves, ask yourself, is the service improving? There are lots of measures that matter in establishing a quality service, and wait time to the first appointment is important, but we mustn't let those headlines hide deeper issues. We need to be looking at the quality of a whole pathway, from referral to diagnosis to treatment to discharge, all being managed safely in a timely way without compromising quality at any stage. So the obvious response to everything I've said is to train and recruit more staff. And you'll hear this said in the media. Build more hospitals, fund the NHS properly. And yes, that is the right long-term answer. But even that takes time that most people don't appreciate. A typical election cycle, of course, is 5 years. But to train me as a consultant surgeon took 6 years of medical school, but even after that, it took 9 years of targeted surgical training. That's a total of 17 years from me leaving full-time education to practicing independently as a consultant. And once you have those consultants, each of a consultant like me can realistically train 1 or 2 trainees through 1 year of their training journey to become a future colleague. Remember, we have a finite operating volume to train these people to do a difficult skill. And surgical skill is transferred case by case, operation by operation, over years of supervised practice. It's therefore not realistic for me to train 4, 5, 6 people all at once. You can't rapidly accelerate consultant numbers without leading to some compromise on quality of training. And so what I'm getting at here is that quality expansion of a workforce can't often happen quickly. It requires steady, deliberate growth over a long time horizon, a genuine generational commitment. I think we can say that about lots of things in politics, can't we? And remember, the same consultants not only are doing planned work, they're also covering on-call rotas, managing the emergency service, running emergency theatres, responding to internal referrals from other departments, providing specialist support to neighbouring hospitals. So adding one consultant to a department doesn't just add clinic capacity, it adds a whole set of hospital commitments that have to be resourced alongside it. So, where does all of that leave us? I've made this video not to make an argument that nothing can be done. It's not an excuse for poor performance either. Neither is it a political statement about any government policy. But I hope what it is an honest account of the structural complexity involved in making NHS services better for our country from someone who deals with it every day. The decisions needed to meaningfully reduce NHS wait times actually involves some genuine trade-offs. And it's important staff, management, and the general public understand this. There are trade-offs between access and safety, between short-term numbers and long-term quality, between what's politically deliverable and what's clinically right. And therefore, the starting question anyone needs to ask about an NHS wait time initiative is not when's the first appointment, it's what's the whole pathway like from referral to discharge? Is it being delivered not just timely, but safely and with the quality that patients deserve? And that's the harder question to answer. It's a less photogenic headline, but it's the question that really matters. If you found this useful, then do share it and do subscribe so you won't miss what's coming next from me. And any thoughts and questions, do pop them in the comments. I will read every one.